Hi, welcome to Respiratory Illness in Children. My name is Terry Cuellar. I'm an outreach clinical educator for SSM Health, Cardinal Glennon Children's Hospital in St. Louis. I'm a nurse by trade, 32 years of kids. That's all I know. And again, welcome to this presentation. So that's me. I'm an old transport nurse. I'm an old pediatric ICU nurse. I'm an old neonatal ICU guy. And that's what I did, and that's what I looked like when I flew. Best job in the world. I encourage you to do that if you have the resources to do that. So I'm going to talk for about an hour and 15 minutes. Again, if you when you complete or when you listen to the whole lecture, there'll be a SurveyMonkey evaluation that you'll need to fill out. Once we verify that that's completed, we'll send you a CEU certificate. I don't have any financial or relevant financial interests, and most of my videos and pictures are from Google. So as far as objectives for this lecture, again, I'm going to talk about considerations when completing a respiratory assessment on children, the difference between different respiratory illness that commonly affect children, talk about risk factors and prevention strategies for these respiratory illnesses that are out there, talk about assessment parameters to help identify distress and failure in kids, and I'm going to talk about specific respiratory emergencies in kids. Janet Moody and Mary Fairchild are both still employees at Cardinal Glennon. They wrote a good meat of this lecture. I just got to put pretty pictures in it, and I appreciate all their help. So why do kids arrest? Why do kids go into full-blown cardiopulmonary arrest? Again, cardiac arrest in kids is almost due to an unrecognized or untreated respiratory failure or arrest. You can also put in an untreated unrecognized shock. Again, kids that go into cardiac arrest, again, they get hypoxemic, and again, their outcomes are poor, especially their neurological outcomes can be poor. Again, half the kids that we promptly resuscitate in respiratory arrest, again, we can save half of those kids when we treat, recognize, and take care of those issues. When kids go into full-blown cardiac arrest, unfortunately, their survival rates are about 10%. So just remember that all patients with respiratory decompensation or arrest without cardiac arrest, again, we can save those folks with proper airway management. So as far as respiratory assessment in kids, things to consider, certainly rate. Know what your references are for normal, not just respiratory rates in kids, but just a normal set of vital signs in kids, normal heart rates, normal respiratory rates, normal blood pressures. But just remember, respiratory and rate in children is not a sole indicator of how bad that kid's in respiratory distress. Remember that a kid that's breathing, or a teenager breathing 60 times a minute is completely different than an infant breathing 60 times a minute. As far as work of breathing and assessing that, again, you see retractions and document, note where those retractions are. Are they subcostal, intercostal, supraclavicular? Just remember with retractions, the higher you see them or the higher that they're occurring, the more distress that kid is in. Do you see nasal flaring? Are they opening up their airways again to oxygenate and ventilate? Audible grunting, again, grunting respirations in anybody is abnormal. Again, breath sounds and what their breath sounds sound I'll talk about assessment. Level of consciousness, remember that when kids get hypoxic and when kids get shocky, they get loopy. And then certainly color, we like nice and pink, we'll tolerate pink and pale. Gray ashen, unless that's baseline, that's not pretty on anybody. And then certainly what their O2 sats are doing. As far as respiratory rates, this is a set of, again, amongst many different references of what a normal respiratory rates are in kids. An ER nurse has taught me this as far as a reminder of normal respiratory rates in kids. She taught me the 50, 40, 30, 20 rule. Remember that infants breathe anywhere from 30 to 60 times a minute, right around 50. Your infant and toddlers, right around 40. Your preschoolers, anywhere from 22 to 34, right around 30. Again, your school agers right around 30, and then your teenagers certainly breathe at the respiratory rates that you and I breathe. But as I said, just remember that tachypnea alone, respiratory rate alone, is not a specific indicator of how bad that kid's respiratory status is. So the little guys, the newborns, just remember that they're nose breathers, they're obligate nose breathers. So when those kids are presented to you and they're full of snot, when I say snot, you might edit that. When they're full of respiratory secretions, again, we need to suction out their nose. Remember that they can have irregular rates and rest periods that last 15 seconds. That's normal, especially for newborns. Just if they're lasting or if they're apneic longer than 15 seconds, we need to make sure and stimulate those guys to kickstart them. They can be abdominal and diaphragmatic in character when they breathe. Again, their breathing can be quiet and shallow. That's normal. Remember that they can be easily altered by external stimuli. I used to have kids in isolates, and you'd bump the isolates, and they'd do that big jerk thing, and then they'd breathe really fast. That's normal for a kid to do that, or for a newborn to do that. Remember that their little hands and feet can turn blue when they're crying, as long as they pink up again. Once they stop crying, that's normal. So as far as increased work of breathing and retractions, again, the picture again, those are pretty deep substernal retractions. Again, when you're documenting retractions, are they suprasternal, intercostal, subcostal, substernal? Just document where you're seeing them. Again, and then nasal flaring, again, their nostrils flaring in order for them to ventilate and oxygenate better. And then the diagram, again, when they get those really deep substernal retractions and they're abdominal breathers, they can do what they call seesaw breathing. And that's that's an infant in big trouble if we don't help. Okay, let's switch to the video. Okay.
You sick, baby? Good. Mr. Lamekins there with you? Huh? Oh. Croupy. Oh, who got the croup? Baby. Oh, yeah. Yeah. Oh.
Okay, so what I noticed in this young lady, as far as breathing patterns, you can hear audible wheezing with this little girl. You can see the obvious supraclavicular retractions. What you can't see is any retractions that are underneath that shirt. So make sure in your respiratory assessments that make sure you're lifting up shirts to see again where other retractions might be. You can hear the audible wheezing. You can hear her cough. She doesn't sound like she's got a croupy cough. And I know Dad does the creepy song, but it doesn't sound to me like croup. Croup's a little bit more obvious, I think. Her skin color, she's pink. She's pale. Again, her level of consciousness, she's obviously awake and alert, interacting. Positioning, I think, in this video is important, and I like how she is positioned and the fact that she's sitting straight up. A lot of times when I would get calls for these kids, their head of the bed would be up, but they'd be scrunched down in a little in the V of the bed. So it was, again, just make sure we're supporting them when we're sitting them up. Okay, that's all I can think of that video. Next video, please. Thanks, Nick. So in this video, I mean, you can obviously notice this, what they're calling tugging, tracheal tugging, and again, the deep sternal retractions. You can hear audible stridor in this young lady. The pacifier, I'd get out of that kid's mouth because that kid's going to focus on sucking on that pass, burn more calories as far as energy, as far as this kid's working pretty hard to breathe. And she's laying, this one is she's laying flat. I'd get her head up a little bit better or have her sitting up a little bit more. Next video.
You're wrong, lad.
Get ready first.
So in this video, you can see, again, obviously this kid's working really, really hard. You can see his shoulders coming up. You can see the deep retractions, intercostal, substernal. What I noticed in this video particularly is the long expiratory phases. So I'm questioning, to me, I'm wondering if this is an asthmatic, which is pretty characteristic. He's kind of barrel chested too. And that's what I noticed in this specific video. Next video. So what I noticed in this newborn, actually pretty newborn baby, again, the color, but you can hear the audible grunting in this kiddo. You can see the retractions. The respiratory rate to me, again, this is a newborn, to me looks a little slow. And again, this is just a kiddo, keep an eye on to make sure that this kiddo doesn't get worse. Okay. So as far as breath sounds and listening to breath sounds, again, wheezing. Wheezing can certainly be indicative of asthma, certainly of an anaphylactic reaction or allergic reaction. Again, crackles might be indicative of a pneumonia or a heart failure. Just remember with your heart kiddos, again, if you don't get a good history, a babysitter calls, just look for those sternal scars, look for those left-sided thoracotomy scars, question heart histories in kids. Decreased breath sounds, again, might be atelectatic airways. Again, and then just remember that grunting is significant for impending respiratory failure if you don't address. So level of consciousness, remember that level of consciousness, especially when kids get hypoxic and when kids get shocky, they get loopy. So again, as far as mental status, are they awake? Are they alert? Are they irritable? Again, are they lethargic? Or hopefully they're not to the point where they're non-responsive when you get there. As far as activity and movement, these little guys, again, take a look at muscle tone or floppy. Are they what I call wet noodled? Are they pale, apneic? Hypotonic, again, floppy muscle tone. Again, as far as responses, and just make sure we're assessing those age appropriately. Do they look around? Do they recognize mom and dad? Again, is this a kid that takes a pacifier, usually chills out with it, but now is still just screaming and irritable air hunger? Do they interact with you appropriately? Just make sure that you're engaging kids and that we're engaging kids based upon, or just remember developmental levels when we're doing that. And again, are we assessing age-appropriate responses according to development? Ways I like to assess kids as far as neurological status. I like colors. What are your favorite colors? Disney is certainly popular. Who's your favorite Disney character? I like holidays. what were you for Halloween? What did Santa Claus bring you for Christmas? Did you see the fireworks for the 4th of July? I might like to use those sorts of questions when I talk to kids, again, as far as assessing the neurological status of their. As far as color and perfusion, again, notice what their color is. Are they pink, pale, gray, ashen? Unless that's baseline, that's not pretty on anybody. Certainly temperatures, make sure we're assessing that through core and through distal. I like to put hands on trunks. I like to put hands on shoulder blades. I like to take little hands and little feet and put them in my hands to see what their temperatures are doing or what their temperatures are. Again, cap refill. Make sure we're assessing that centrally and peripherally, especially in the little guys. I like to use palms versus little toes and little fingers. I like to use palms. Palms of hands, not little toes and little toes. I like to use soles of feet. In the bottom of the feet, centrally, I like sternums. And again, one other place I like is foreheads. It's where I like to assess, especially the little guys. Remember, modeling is hypoperfusion. Modeling to me, someone told me, looks like splotchy chicken wire, and that's how I remember it. It's just a visual for me. Just remember, if you've got delayed cap refill, consider the temperature of your trauma rooms, consider the temperature of your at the back of your ambulances, because if those are cold, again, it might be the reason that their cap refill is delayed. As far as pulse oxes, continue to use them. Just remember that if they're hypoperfused, again, just make sure you're getting a good plethora, that you're getting a good waveform. I like the picture of the foot because that's a way to put a pulse ox on a little guy versus putting it on a big toe. Your pulse ox may not be, you may not get good contact with that. And then capnography, continue to use capnography, use the technology that's out there. Remember that it is a more sensitive indicator of ventilation. And again, get it in line. You can put a nasal capnography and a non-rebreather on top of on somebody, again, just to make sure that you're getting a capnography reading. So as far as respiratory viruses and viruses that are out there, just remember, in a study of nearly 100,000 pediatric admissions, the most common cause for hospitalization for these guys was respiratory, and in the keyword there, it's viral. A lot of folks want antibiotics, and antibiotics are prescribed. We need to remember that it's viral. We can treat the symptoms, we can treat the fever, treat the cough, but again, it's viral. It needs to run its course. Again, and remember that there's seasonal peaks and valleys for a lot of respiratory bugs.
This is Nick with the STARS program. For those of you who don't know me, my background is in EMS. And we figured at this particular time there might be some questions related to COVID-19. First and foremost, this is an incredibly dynamic situation, so please use your good references, such as the CDC, such as your medical director, the state resources, to have the most up-to-date information. Surely anything I say in this video will time out shortly. There is some things we did want to reiterate from our perspective at the pediatric hospital. First of all, there's not really good data on less than 20-year-olds. It seems like they experience a lot of the same symptoms that our adults are experiencing, but they tend to be milder. In some ways, we kind of think that they're probably one of the main vectors for this infection because of that, or for this pandemic, because they have really mild symptoms. No one really recognizes that they were that sick, but they're hanging out with everybody else. And so they certainly can get it, but it seems less likely for them to have a severe infection, as we're hearing about from a lot of other patient populations. If you do run a pediatric patient that you think might have COVID, so once again, rely on your local protocols first, but it seems like they're developing a lot of methods here for us to consider alternative treatments. So if you have an incredibly stable patient and you have that option available to you, please consider it. And then if you do transport to your ED, please, we need to notify the receiving facilities that you suspect a COVID infection. They are having to triage differently. They're having to put those patients in different areas so that we don't spread the infection within the hospital. So It is absolutely paramount that when you call in that patient report, you report if you think you have a patient with COVID. One thing that will affect your care a little bit, if you have that patient that you're transporting and you think they might have a COVID-19 infection, we are hearing a lot for not using nebulizers. So once again, I encourage you to follow your local protocol, but it seems like a lot of the state resources, a lot of the state medical and regional medical directors are suggesting that we not use albuterol nebulizers because of aerosolizing the infection around the entire room of everybody standing in that room. And so that's not really recommended. They are recommending instead you use the patient's MDI, which is also a meter dose inhaler of albuterol if they have that available. Or if your patient's severe and you are in the back of the box with them, and you think you don't know if you have asthma, of an infection, but you think you might have COVID, you're possibly going to go straight to your EpiIM to treat the respiratory symptoms, because you don't want to be using the neb in the back of the truck where you are working. If you do have to proceed to a point where you're doing more advanced airway management and ventilatory support for one of these patients, certainly try to have filters available on the exhalation ports of your BVMs. I know we're a little bit resource limited currently, but if you at all possible can find filters to go on your BVMs so that you're not immediately, once again, aerosolizing the infection all around the back of your box while you're transporting. It seems like a popular response, and I'm sure we'll hear more about these in upcoming days. But if you have to do advanced airway management, considering the use of a supraglottic so that you do not have to get your face down close to the patients while you're trying to intubate. On that note, if worst case scenario you are proceeding, you're having to do advanced airway management on a patient with a potential COVID infection and you need a tube on them, there are at least some advanced circles of critical care who are suggesting you go to your paralytics. Certainly always a sedative with your paralytics, but the idea that you knock out your patient's respiratory drive out, they physically cannot breathe, they cannot exhale. A lot of your medical directors are currently in talks with regional and state medical direction with regards to possibly having us under special sets of protocols for this particular crisis, and that some of them will include different parts of these elements. A lot of those are still ongoing talks. We're still learning a lot more about COVID, but just kind of be aware of that. I can say, very fortunately, at least it appears in the beginning days here for pediatrics that they are much less likely to get the severe infection and to require the advanced hospitalization that we're hearing so much about in our adult patient populations. So I just wanted to add that in there. Please, as I said, follow up with your other sources of education on this, and we will hopefully all learn more and get better. And I certainly hope all of you are able to stay safe out there. Thank you for what you're doing.
As far as the adult versus pediatric airway, remember that the pediatric airway is shaped like a cone, usually until the age of 8. So if they swell, if they eat a Skittle and obstruct, if they've got a lot of secretions again, and now I'm premature, I've got lung issues again, I don't have the reserve to help my respiratory status. Again, in the adult, it's more of a cylindrical shape, and they reach that. They get that when they're around age 8. So epiglottitis. Remember that epiglottitis is supraglottic. It's above the vocal cords. It's usually caused by H. flu type B. Remember that it's usually age 2 to 6 years old. Again, it's usually a rapid onset. They may or may not have a cough. You may hear stridor because of the narrowing of the airway. This can be life-threatening, especially if they totally occlude and these kids look sick. With H. flu being introduced to our immunization series in our kids, again, we weren't seeing so much epiglottitis. We weren't seeing so much meningitis in kids. So we rarely see epiglottitis if their immunization status is up to date. In the pictures, one is an epiglottis, one is a swollen epiglottis, and then that's a bad epiglottitis. I can't imagine attempting to intubate that kiddo. You certainly will want your best intubator to do that. Again, you bounce on that epiglottis. Again, they're going to swell, and then you've got bigger issues. So as far as management, you want to allow these kids to get in a position of comfort. Again, allow parents, allow them to sit in a parent's lap. You can give blow-by. What I had a rule out epiglottitis. I got my vital signs off monitors. I had a 18-monther. I had the mom put the thermometer under the kid's shoulder. I didn't want to freak her out. I didn't want to compromise her. Again, oxygen you can give him by blow-by. Then my kiddo was sitting on his mom's lap. I had blow-by in a mask, which was fine. And again, certainly had a cried kid at the foot of the bed. And our anesthesia knew she was in house. ENT knew she was in house, and this was when I had her in the ICU. So croup. Remember with croup that it's a subglottic area that's affected. It's viral. It's usually parainfluenza 1. Onset for these kids is usually 3 months to 3 years. The onset can be slower. It's that loud, sealy sounding, barky cough that's diagnostic, or pretty much diagnostic of croup. The stridor can get worse at night because we lay these kids flat in bed to go to sleep. It's usually self-limiting. It's usually mild. Again, unfortunately, it can lead to significant airway obstruction. I personally haven't heard of anyone dying, but I guess it can happen. So as far as management of croup, it's cool mist. Again, in the summers, if it's humid, you can take them outside. Humidifiers can be helpful. Again, you can give them oxygen if needed. It's humidified oxygen. These kids, you want to make sure you don't want to make them mad because you don't want to get them into a coughing fit such that they would poop out. If once they poop out again, it could be a respiratory arrest. As far as racemic, continue to use it. And there's the dose there. Just be aware of a rebound effect. If you give them too close together, it actually can make them worse. So as far as upper respiratory infections, certainly there's the common cold. Enterovirus D68 was the bug that hit us, I think, 4 years now in August in the summer, that was putting healthy asthmatics intubated in hospitals, and then certainly the flu bug. So bronchiolitis, remember bronchiolitis is an infection of the lower respiratory tract. Again, leads to inflammation of the bronchioles, edema, and then mucus plugging. Causes of bronchiolitis, certainly RSV or the respiratory syncytial virus. Again, flu can cause bronchiolitis. There's parainfluenza, adenovirus, rhinovirus. Again, lots of bugs that can cause bronchiolitis in kids. So as far as RSV or respiratory syncytial virus, it's the most common respiratory pathogen in our infants and our young kids. Again, causes 80% of bronchiolitis.
Hey, Terry.
Yeah, bud.
Hey, sorry, can we go back to croup? My Wi-Fi dropped in the middle there. Sorry, bud. So I gotta see, I'm not even sure. I think we're recording again. Yeah, it says it's recording. Okay. Yeah, if you don't mind starting again with croup, and I'll cut and splice later.
Not at all.
All right.
How's it sounding? How's it working? Does it sound okay?
So yeah, it's pretty good. I noticed just like 3 different times I've had a little bit of like a second long pause on yours, but like you could clearly tell like what you were about to say and have it come out fine on the other side.
Okay.
And I don't know if that's you or me. I might have to work on my Wi-Fi over here if I'm gonna keep doing this, because
Oh.
that was where I haven't had that happen in the last week. It just like completely knocked me off for a second. So
Really? Oh, that sucks.
yeah,
Okay.
Other than that, it's great stuff. I forgot you had all these good pictures in this lecture, so I think it's all coming across super well.
I don't know if they're copyrighted, but I guess it doesn't matter, right?
Yeah,
Because we're
I'm
not
gonna go
selling
a
them.
little bit with ask for forgiveness later instead of
Right.
permission on some of this stuff. So all right, cool. I'm gonna mute, and yeah, if you don't mind just kicking back in with croup.
Okay. 3, 2, 1. So croup. Just remember, croup is a subglottic tracheal wall. It's the area that it affects. most commonly caused by parainfluenza 1. Again, age of onset is usually 3 months to 3 years. The onset tends to be slower in these kiddos, and it's that loud, sealy sound and barky, harsh cough that can be diagnostic of croup. Again, these kids can get stridorous because we lay them flat at night to go to bed. Usually it's mild and self-limiting, but again, may progress to airway obstruction. Rarely do kids actually die from croup. So as far as management, again, cool mists, certainly humidifiers. You can, again, take them outside in a humid day. You can aerosol, again, just a neb in the ambulances, just the humidity is what they need. You can certainly give them oxygen if you need to. These are the kids that you don't want to get into a coughing spell, so you want to minimize your disturbance with them. Again, don't want to get into a coughing spell such that they go and can't stop coughing and go into respiratory failure. As far as racemic, again, it's 0.05 milligrams per kilo to a max of 0.5 mils, 2% racemic and 3 mils of saline. Just remember there's the racemic epi. Don't give them too close together. They can actually get a rebound effect, can make them worse. So as far as upper respiratory infections and the bugs, certainly there's the common cold. Enterovirus D68 was the virus about 4 years ago that hit our kids in, I believe, in August. This bug was putting healthy, compliant asthmatics, unfortunately, intubated in our pediatric ICUs, and then certainly the flu bug. As far as bronchiolitis and infection, remember that it's an infection of the lower respiratory tract leading to inflammation of the bronchioles, mucus plugging, and then edema. Causes of bronchiolitis, certainly RSV or respiratory syncytial virus, certainly the flu, again, parainfluenza or other viruses that are out there, adenovirus and then rhinovirus all can cause bronchiolitis. Lots of bugs that can cause this. So remember with RSV, that RSV is the most common respiratory pathogen in infants and young kids, can cause 80% of bronchiolitis, up to half the pneumonias in little guys. Again, symptoms can look certainly like the common cold initially. As far as prevalence, again, when kids are exposed to RSV for the first time, almost half of these kids have signs and symptoms of bronchiolitis or pneumonia. It's the most frequently cause of putting our premature infants back in the hospital. Again, 125,000 hospitalizations. Most of these kids are less than 6 months of age. And virtually all infants by the time they turn age 2 have been infected, at least exposed to it. Again, high risks for complications, certainly your premature babies, because their lungs are immature, BPD or bronchopulmonary dysplasia, again, another disorder or disease of prematurity. Congenital heart disease, again, this can certainly be life-threatening. Again, 2% of all infants hospitalized for RSV, unfortunately, won't make it out of the hospital. But a quarter or almost a third of those deaths, again, these are kids that have other congenital disorders, again, called cardiopulmonary conditions. So as far as symptoms of RSV, certainly nasal congestions and just copious amounts of nasal congestion. You can have a runny nose. Again, if my nose is plugged, I'm not going to feel like eating, and when I can't eat, I'm crabby. These kids can run low-grade fevers. Again, they can have the coughing and sneezes. Again, wheezes and rails, especially if they've got concurrent lung issues. And the little guys, again, it's almost like a flu. They're going to be irritable, especially if they can't eat, especially if they can't breathe. Again, they can have the general malaise like you can with flu. Again, if I can't breathe, I'm not going to eat well. Just remember that RSV in itself can cause apnea spells. As these kids get worse, again, they start coughing deeper, they can breathe faster, they can have difficulty breathing. Again, their skin color can be poor. Again, and this is when they might need an oxygen requirement. Remember that most bronchiolitis is diagnosed clinically and in the doctor's office. Just certainly this kid will buy a full septic workup, especially if they're running fevers, again, especially if they're at risk or have risk factors that, again, that might make them septic. So other risk factors, not just for RSV, but certainly for all respiratory bugs, certainly prematurity because those kids are born with immature lungs. Any chronic lung disease or any congenital heart disease can put these kids at risk. Certainly attendance at daycare because our kids normally don't wash their hands and they're in close proximities. Again, exposure to crowds and kids that are exposure to crowds, again, just puts people susceptible. And exposure to tobacco smoke again gets in the lungs and can put them at risk. School-age siblings, big brothers and sisters, because we don't wash our hands. Again, being born or discharged during RSV season, I can put these kids at risk. And then certain multiple births, if I'm a twin, I'm a triplet, I'm a quad, probably was born a little premature, might have immature lungs. So Synagist, again, it is the injection that is effective prevention against RSV. It's a monthly injection that's given during RSV season. And again, these are indications for the Synagist, again, kids less than 2 with chronic lung disease, premature infants or infants born less than 32 weeks, and then infants 32 to 35 weeks with those risk factors. So as far as management of respiratory issues with kids in the ED, certainly in the back of your ambulances, just remember bulb syringes. It sounds silly, but you make sure you squeeze the bulb before you put it in a kid's nose to get the snot out. We need to get the snot out. When I used to pick up these kids, our respiratory therapist taught me we wouldn't even mess with bulb suctions. We'd get a suction catheter out, a couple drops of saline, a 5 French and 8 French catheter, and deep suction them. And make sure you don't go too deep because you don't want them to vagal. You don't want to drop their heart rates. Again, continue to use bulb suctions, continue to use neosuckers or special small pliable neosuckers, and then delete suctions. Delete suctions are back. Again, you can buy them at the pharmacies, at Target, all those kinds of places. Certainly, if I had a premature baby or I had a kid with a trach, I'd probably have one of those in my glove compartment. This was an article I found almost 7 years ago. If you read, essentially, this guy, I heard a 911 call, and he found a turkey baster, got a turkey baster and cleared these kids' secretions. She smiled at me, and I knew we were in the good. So get the secretions. As far as management of bronchiolitis, certainly get your pulse oxes on. Make sure you keep their sats up with oxygen. They haven't been eating, haven't been drinking, and running a fever. They're going to be dehydrated. So again, they might need fluid and rehydration. Be good at your IV skills. Again, bronchodilators aren't supported by the data unless there's recurrent wheezing. And then unfortunately, these kids might need to be mechanically ventilated. So as far as prevention, again, stay away from sick people. Encourage folks to stay home if they're sick so we don't spread respiratory bugs. And it's hand washing. Again, if you don't, again, alcohol-based is out there, but again, just good old-fashioned soap and water for 20 seconds is a good prevention. Make sure we're cleaning our surfaces, we're disinfecting. Side rails, again, side rails on your stretchers. Just make sure we're cleaning them. Doorknobs, make sure we're cleaning those effectively. Hey, Nick. Nick, are you there?
Yeah, I'm here, Terry.
Yeah, this slide, I don't know the number, but I don't have authorization for this child's picture. So I don't know.
All right, I'll cut this part.
Yeah, I'm just skip this through this.
Cool.
Don't
Is
know who it is.
there a question slide at the end as far as I'll pop in with the COVID stuff?
Okay. Yeah, just I forgot I had this in here. I use it when I teach, but I don't know who the child is and don't have a press release to use it. But it shows
Yeah.
how,
Well, you
it
know
shows
what
how
though?
stupid they are.
You
I don't know.
know, is that from Glennon?
Is that picture from Glennon?
Yeah.
I don't, it was just a screenshot I took.
Oh, okay. Because I was gonna
It's the
say,
kid.
I mean, if that was a kid out of Glennon, we got a press release for him somewhere.
Oh, well, that's true too. You know what? I'd have to look at the video, but I think it is a Glennon kid, actually.
Gotcha. I'll leave it
But
up to, I
just
tell you what. If
just
you
a
want to
thought.
cover it just in case, or I can cut it out later.
Um, I'm sure I can talk about it, and yeah, you can edit it out if you.
All right.
I, um, okay, take 4. Um, again, don't expose our newborns to crowds. This kid is with Santa Claus, and Santa Claus is at the mall, and I bet he doesn't change his gloves. So again, don't expose, if possible, don't expose our newborns, especially to crowds and during respiratory season. Other prevention issues, we can certainly encourage our parents to quit smoking. Make sure they're getting vaccinated, especially for flu, not just for their own sake, but for the sake of their kids. Again, certainly cover our mouth and nose when we're coughing and sneezing. If you're coughing into Kleenex again, or tissues, make sure you're disposing of those and washing your hands when you're done. So quickly about asthma. Asthma accounts for 14 million lost days of school annually. Asthma is the 3rd ranking cause of putting our kids less than 15 years back in the hospital and costs our society some $3.2 billion per year. So be an asthma doctor or an asthma nurse. Job security. Remember with asthma that it's this bronchial constriction with smooth muscle contraction, can lead to airway edema, certainly hyperresponsiveness, and then airway remodeling. I'm going to pause for a sec. I'm just making sure this text isn't from Josh. Okay.
Cool.
I don't want to mute that. Okay. So risk factors as far as asthma, and these were red flags for me when I was at the bedside and especially when I transported. These are questions I would ask of teenagers and parents when I got calls for asthmatics. They've been so sick they've needed to be in an intensive care unit. They've been so sick that they needed a breathing tube to help them breathe. Again, are they needing to call the doc for multiple courses of steroids? Are they using their inhaler a lot to help them breathe? And again, this is poor compliance with treatment. This is also a need for education and re-education for our asthmatics. And then are they frequent flyers? Are they frequent flyers to the emergency rooms? Yeah, are they known frequent flyers? Again, this is where education can be very beneficial. So as far as assessment, again, are they using accessory muscles to breathe? Again, do you see retractions and document where those are? This was a red flag for me. Are they so short of breath that they can't speak to me in full sentences? The picture there, what's missing is a spacer. Again, spacers are better distribution of the medication. So that kiddo needs a spacer with his inhaler. Are they breathing fast? Again, are they having to tripod or position themselves so that they can breathe easier and open up their airways? What their O2 sats are doing? Again, peak flow and peak flow meters. We're doing more and more education with kids and with parents with peak flow meters so that they know their numbers, if those numbers are decreasing, again, to know when to call their physician when they get in trouble. And then asthma scoring. Asthma scoring is something that we do specifically at Glennon, and I'll review that. So as far as management, again, give them oxygen to keep their sats up, give them their bronchodilators. Again, that kiddo needs a spacer. Again, steroids can certainly decrease inflammation. Just remember with oral steroids and oral steroids, especially the syrups, that they're not the best tasting. So disguising those flavors can be a challenge to get a kid to take PO steroids, especially a little guy. Again, give them their anticholinergics to help with the beta 2s. So as far as management at our hospital, again, the therapies remain the same no matter the severity. It's the dose and frequency of reassessment based upon how bad they present. Just remember with your beta 2s, they can use MDIs versus nebulizers. That little guy's got a spacer so that he gets his medication more effectively. Again, continuous versus intermittent. That's a continuous setup that we use. It's extremely easy to use and set up. And then Zopanex versus albuterol. Again, a lot of folks are going just straight back to albuterol. So that's the asthma scoring that we use at Cardinal Glennon based on SATs, auscultation, accessory muscles, respiratory breath sounds, and then again, how short of breath or how dyspneic they are. Our kids are scored from 0 to 10, and based upon that score is how we initiate treatment. So your asthma score is less than 2. It's a single dose of albuterol based upon their weight. At 3 to 4, they're given a continuous albuterol where we add Atrovent. And then this is when we'll start steroids, PO. And then it's your 5 to 10 asthma scores. It's continuous albuterol, now Atrovent, and then IV steroids. Again, if their scores are so bad, again, we can consider alternative therapies. Just remember with asthma scoring, that it puts us all on the same page, like a GCS score can, like an APGAR score can. So if you call me and you've got an asthma score, you tell me your asthma score is 8. Again, it just tells me how severe that kid is. We're all talking the same language. Again, just remember with a key point is, at least in our ED, that again, admission decision is going to be made within 3 hours. So they're going to be there for a little bit. So for your asthma score 0 to 2, these are our albuterol doses. Again, over 15 minutes, and that kid is reassessed in an hour. Again, your score is 3 to 4. It's continuous albuterol. We add Atrovent, and this is when we start. That treatment is over an hour, and this is when we start considering oral steroids. And then your kiddos, again, 5 to 10. It's still albuterol and Atrovent, again, over an hour, and this is when we're going to consider IV steroids. So other managements or other therapies you can consider as far as managing asthma, certainly epi, sub-Q epi. Again, you can repeat this for a max of 3 doses. IV mag is what we're using more. Just remember that mag sulfate is a smooth muscle relaxant, so it's good for opening airways. I've gotten questions about nebulizing it. I personally haven't seen it or heard of it, but I've been told that they're doing studies on adults. IV terbutaline is an old smooth muscle relaxant we use with pregnant women. I've seen that used for asthma. And then ketamine. We're starting to mainly ketamine for intubation. Just remember that with ketamine, your high sedation doses are your 1 to 2 milligrams per kilo per dose. For anxiety, remember with ketamine that it's got a bronchodilator side effect into it, so that if I'm air hungry, I'm on oxygen, albuterol, you're giving me everything, and I'm still air hungry, you take the edge off again with a low dose, and this is a one dose of ketamine that we use. It's 0.5 milligrams per kilo per dose IV. It opens up my airway and chills me out a little bit. Again, my therapies will be better or will be more effective. So specific respiratory emergencies, certainly epiglottis. Again, let them get comfortable. Again, make sure you've got a cry kit. You can update your immunization status or ask about it. Just remember that all kids ages 12 through 59 months, 1 year to 5 years old, can get 1 dose of Hib. Epiglottitis. Again, I've never seen a needle cry, but remember that if you're needling, again, you're bagging through a small hole. It's a slow, long ventilation. Again, you can certainly try to intubate. With an epiglottitis, you're going to need your best intubator. You're going to get 1 try, then things going to swell. As far as foreign body aspirations, remember that most of those are little guys less than 3 years old. Again, they're usually main stem or lobar. They rarely go deep end of the tracheobronchial tree. Their histories might be unclear. Again, chest x-rays might be normal. And then these kids probably need a bronch. Just remember with button batteries, you get a button battery history that needs to come out. That can certainly burn and cause perforations. So those are some x-rays. Kids like to eat money. I like Mickey Mouse. This picture, again, is a highlighter. That's a highlighter cap that's below vocal cords. This is a kid that needs bronch soon, and this is a kid that needs to be calm, certainly and upright. So tracheostomies, and so just remember with trachs, know your protocols. With some of the education that we've been doing, we found protocols that allow folks to pull trachs, to suction trachs, to pull trachs, but they can't replace them. So know what's your protocol. Just remember a trach, it's an airway, it's a crucial airway. Again, remain as calm as possible. Again, remember that it's airway first. It's always the trach first, and troubleshoot that trach. Ask for the bag. Our kiddos are sent home with a backpack that's tagged. It's your crash cart, your spare trach, same size smaller, suction catheters, bulb suction, ambu bag, gloves, hand sanitizers should all be in that trach bag. I had a family that kept a small O2 tank in theirs too. This bag is supposed to be with this kid 24/7. Hang on, Nick, I'm getting a text. I'm just making sure it's not Josh.
Gotcha.
Okay, it's not. God, I was just thinking of him. Okay. Let's see. Okay. You want me to start this slide over? Would that be easiest when you edit? Easier when you edit?
Sure. Either way, I don't remember exactly where you were, so.
Okay. I'll just keep going because I'm on a roll.
Right.
Remember that a trach tube is a very stable airway if it's patent and it's secured. And just remember with trachs, again, use your parents or your caregiver as resources. They deal with this 24/7. You can certainly ask them, again, what have they already done? Have they suctioned the trach? Have they changed the trach already? But just remember, if they're interfering with your care, especially if they're over anxious again, they may not be able to help you, and you'll need to take charge. As far as suctioning, remember that when you suction a trach, you suction on the way down and on the way out. Give your catheter a twist and turn because you want to remove as much secretion as you can. Make sure you're documenting the color, consistencies, and the amount of secretions that you're getting out. Again, and reassess their respiratory status. You can certainly attempt to give bag breaths with your ambu bag. You can put saline down the trach. Again, bag it down to help loosen secretion, suction them out. Again, if the chest does not rise, and you'll notice this quickly, you'll notice that in the resistance in your ambu bag. You'll notice, again, you don't have to go very far to know that that you can't get past the cannula to suction that trach. Make sure that there's no kinks or dislodgement in the equipment, but again, assess the patency quickly. Again, if you still don't see chest rise, you can put or instill saline into the trach to suction it out. Again, do a good assessment once you get those secretions out. So again, if you still see no improvement and you're not able to pass that catheter, you're gonna need to change the trach. Again, make sure you loosen the ties. Some of the trachs, there's 2 ties on the side and a big tie, and most ties are Velcro. There's a big tie in the back, and that's the tie that's easiest to loosen. I like shoulder rolls or neck rolls because I have to get to the neck, especially if I have to change that. Again, if you've got a bulb, if you've got a tracheostomy with a bulb, make sure you deflate the bulb because it's going to be easier to remove that trach. Again, you pull the trach one swift moment and put the new trach in. We teach our parents with the spare trachs to have trach ties on, obturator in, and those trach ties trimmed to the right size so that you can secure it. We teach our parents to keep the same size in the bag and the size smaller just in case you pull that trach, that stoma, and assess that stoma. If it's swollen, a lot of secretions, and you can't get the same size in, and they're instructed to have a size smaller to replace that trach. If that's the only trach that you have, they don't have a spare, again, make sure it's patent and put it right back in. I'd put it back in, give you antibiotics for pneumonias, tracheitis. But if it's your only airway, I would replace it with the old one. Tension pneumos, and that's an X-ray. Again, decreased venous return, again, due to big vessels getting kinked. Again, as far as pathophys, again, is it encroaching bilateral lung encroachment? Are you getting decreased venous return? So they're getting shocky looking. Again, are they having tachypnea? Are they turning colors? Or are they having gasping respirations? And do you hear decreased breath sounds? Just remember, tracheal shift is a late sign, especially in kids. And again, neothoracostomy, again, with chest, and then a chest tube might be needed. As far as needle thoracostomies, again, you want a large bore over this 2 to 3 inches long. Again, you want to prep the site. It's the second intercostal space, mid-clavicular line, above, over the rib is how I remember it. Again, you want to go over the top of the third rib. And again, you want to insert that needle until you hear air release and advance that catheter. And then when they put in the chest tube, again, it's 4th or 5th mid-axillary. Again, emergently, you won't have time to anesthetize the site. And again, I don't put in chest tubes, but that's how the doctor does it. Remember, with intubation, again, you need to prepare for potential intubation, double check your equipment. Again, make sure you've got the right size bags and masks, the right size oral airways. Again, make sure your suction is set up. Make sure you've got small blades and in your laryngoscope bulb works. Again, take a look at all your ET tubes. Remember, PALS teaches us as far as proper ET tube sizes, the pinky finger. And then a quick formula for sizing an ET tube. It's the age divided by 4 plus 4 for uncuffed tubes. Same formula, age in years divided by 4 plus 3.5 for cuff tubes. Again, I had the luxury of sedation when I intubated. Again, Sux, Vec, and rocuronium are different medications that you can use. Just remember, if you are, especially if you're muscle relaxing, make sure your bag is ready for when they go apneic. As far as trauma, again, take care of your airway and breathing problems, more common than your circulatory problems. It's ATLS, like we learned in all the courses that we take. And again, make sure you're identifying and treating life-threatening injuries first. So in short summary, again, respiratory bugs are one of the most common reasons for pediatric ED visits and hospitalizations, especially with the infants. Prioritize your airway, breathing, and circulation. Manage hypoxia with oxygen. Again, if you recognize the respiratory issues, take care of them and treat them before they go into respiratory arrest. Before they go into cardiac arrest, again, we can save these folks save our kids with proper airway management. Know what your protocols dictate to you, your guidelines on what they dictate to you that you can do. And any questions, again.
All right. And Terry, did you have anything else for the pediatric lecture?
Oh, nope, you're good.
Okay. All right. Thank you guys very much for attending this today. There will be a follow-up email with a link to your standard quiz and survey regarding this training. Once you fill that out, on just about a weekly basis, we're going in there and sending out certificates. So hopefully within 48 hours after taking this, you will receive your quiz and survey. And then sometime within the next week, you'll receive your certificate after you fill out that quiz and survey. So thank you guys for your time today, and be safe out there.